Magandang araw po sa inyong lahat. Today, we will talk about the metabolic conditions of hyperuricemia and diabetes mellitus. Let's start with hyperuricemia. Gout and hyperuricemia are two terms that are often used interchangeably, but they don't actually mean the same thing. Both involve the presence of excess uric acid in the body. However, gout refers to the extremely painful swelling and redness of the involved joint, while hyperuricemia simply refers to elevated serum uric acid levels with or without the pain. Both of these conditions emanate from the same metabolic process, which is the breakdown of purines in the body. These nitrogen-containing substances are important energy sources, and their utilization results in the production of uric acid, which is the element measured in the blood, or which is found as crystalline deposits in the joints. So where do purines come from? They can come from exogenous sources like food, and the other half is due to purines manufactured by human cells. The accumulation of uric acid in the body is primarily driven by evolutionary changes. Mammals have the enzyme uricase, which breaks down the purines into allantoin, and this is easily excreted from the body. But uricase is no longer present in the human body, and instead, purines are converted by the enzyme xanthine oxidase into uric acid, which then accumulates within the body tissues. So the main difference between hyperuricemia and gout is that hyperuricemia is due to underexcretion and overproduction of uric acid, while gout is more commonly due to underexcretion of uric acid. Gout is classified into two types: primary, which may be idiopathic or due to an enzyme defect, and secondary, which means that the rise in uric acid levels is due to drug therapy or other metabolic conditions. The most common causes of secondary gout are excessive alcohol intake, renal insufficiency, thiazide diuretics, and other hypermetabolic conditions such as leukemia, psoriasis, or other medications. Gouty arthritis usually affects the joint at the base of the big toes, but it may also cause pain and swelling of ankles, knees, wrists, fingers, and elbows. Gouty attacks are usually described as sudden and rapid onset of pain and swelling of affected joint, followed by warmth, reddish discoloration, and marked tenderness. The attack may take hours to days to resolve, and this may occur with or without medications. Tophi are deposits of uric acid crystals in cartilage, tendons, and the soft tissues around the joints, resulting in marked deformity. What are the risk factors for gout? First is age. This excruciatingly painful affectation may affect middle-aged and obese adults who are often heavy alcoholic drinkers and afflicted with hypertension and hypercholesterolemia. The elderly are also more prone to gout because of deteriorating kidney problems and the use of diuretics. A second risk factor is gender. Men are more at risk for gout and may experience their first attack between 30 and 50 years old. Premenopausal women rarely get gout, but once menopause sets in, then they begin to catch up with the incidence rate of the men. A third factor is family history, which would suggest that a predisposition for hyperuricemia may have been passed from one generation to another. However, people who are obese, with heavy alcoholic use, who have thyroid dysfunction, and use diuretics have the greater chances of developing gouty arthritis. How is gout treated? Let's start off with lifestyle modification, namely weight reduction, decreased alcohol ingestion, and control of dyslipidemia and hypertension. Then there is the need to adjust the diet to minimize the intake of purine-containing foods. These are some of the foods most people are advised to avoid: anchovies, sardines, scallops, organ meats, gravy, yeast, and mushrooms. Unfortunately, most foods contain purines in varying amounts, so instructing patients not to eat anything that contains them is tantamount to saying don't eat anything at all. Therefore, a better way of recommending a proper diet for gout patients is to list down those that have a low purine content and how often they can be taken to avoid an undue increase in their serum uric acid levels. Let's presume that the patient has tried his best to control his food intake, but he still gets a bad attack of gout. What will need to be done? Well, colchicine is the recommended first-line drug, but it only works against the inflammation and does not relieve the pain. So an analgesic such as mefenamic acid or naproxen may be needed. Steroids, on the other hand, are used only when NSAIDs and colchicine are not effective or are contraindicated. Once the painful gouty attack has settled down, then the next task is to decrease serum uric acid levels, and this is done through the intake of uricosuric drugs like probenecid, which increases the excretion of uric acid through the urine, or by starting therapy with xanthine oxidase inhibitors such as allopurinol or febuxostat. What are the therapeutic targets? The minimum target is to reduce uric acid levels to below 6 mg per deciliter, although levels of below 5 mg per deciliter may be needed for the resolution of gouty signs and symptoms. The first drug of choice would be allopurinol or febuxostat. Both of these drugs prevent the formation of uric acid by blocking xanthine oxidase. However, one must not forget to drink plenty of water to avoid dehydration, facilitate the excretion of the existing uric acid crystals, and prevent formation of kidney stones or the occurrence of a repeat episode of gout. Gouty arthritis is usually described as a burning and excruciatingly painful experience that one would not want to wish upon his enemies, so it is always a good idea to keep uric acid levels under control. Now we proceed to our discussion on diabetes mellitus. Glucose is the main source of energy of our cells, but the gate through which glucose enters is controlled by insulin. In the normal body, insulin is always present to open the gate. But what happens in diabetes? There are two general types of diabetes. Type 1 is an autoimmune condition brought on by the destruction of the insulin-producing beta cells of the pancreas, resulting in little or no insulin production. As a result, blood glucose levels rise because there is no insulin to allow them to enter the cells. Type 1 diabetes only constitutes less than 10% of diabetes cases and is often associated with early age of onset, but this may still occur even among adults. Type 2 diabetes is a bit more complex. It usually starts with a dysfunction of the insulin receptors, making them non-responsive or resistant to insulin's effect. This is the beginning of the period usually termed as pre-diabetes. Since the glucose levels continue to rise, the pancreas responds by continuously increasing its production and secretion of insulin. This compensatory increase in insulin production and secretion eventually leads to exhaustion and damage of the insulin-producing beta cells of the pancreas, causing a drop in insulin levels. Thus, type 2 diabetes mellitus is a product of both the development of insulin resistance and a drop in insulin production over time. These conditions result in uncontrolled glucose levels in the body, which in turn gives rise to an environment that promotes inflammation, cellular damage, and the enhanced progression of atherosclerosis and its major complications, which include stroke, heart attacks, and death. This is a summary of all the physiologic changes that occur in the development of type 2 diabetes. In the blue shaded area, You will see that prediabetes may start as early as 15 years before the actual onset of diabetes, starting with a rising insulin resistance and insulin levels and a rising fasting and postprandial glucose levels. In fact, it is postprandial glucose which rises first before fasting glucose. Once insulin production starts to drop and fasting glucose rises above the cutoff level of 127 milligrams per deciliter or 7 millimoles per liter, then the diagnosis of diabetes is made. This illustration is meant to emphasize the point that diabetes is a product of the interplay of insulin resistance and dysfunction of many different organ systems, from the brain to the intestinal tract to muscles and fat and the immune response. All of these contribute to the eventual destruction of the pancreatic beta cell, which pushes the body into the state of hyperglycemia. These are the common symptoms of full-blown diabetes: excessive hunger, excessive thirst, weight gain or undue weight loss, frequent infections, erectile dysfunction, numbness of hands and feet, and blurring of vision. But why wait for these symptoms to occur? It would be better to adopt a more proactive stance by doing regular screening, especially if you have family history. So, how is diabetes diagnosed? It all boils down to testing blood sugar levels. These are the cutoff numbers to remember in both SI and conventional units. Diabetes is diagnosed when you get a blood sugar value of 7 millimoles per liter or 126 milligrams per deciliter or higher, taken on 2 separate occasions. However, any random blood sugar which reveals levels higher than 11.1 millimoles per liter or 200 milligrams per deciliter will already be considered evidence of diabetes. Controlling diabetes is not an easy task and will involve a lifetime of effort. Dietary control is the primary intervention, and it is recommended that the patient avoid simple sugars and instead take a balanced diet of complex carbohydrates, such as vegetables and whole grain and legumes, low-fat proteins from fish, a controlled amount of fruit, and plenty of water. Increased activity levels are also recommended for everyone to achieve overall cardiovascular well-being and stable weight management. However, most cases of diabetes will not be controlled so simply, and the discussion on drug therapy inevitably comes up. This is taken from the General Management Recommendations of the American Diabetes Association in 2014. They recommend that the tightness or strict implementation of sugar control should be tailored based on each patient's clinical status. If disease duration is short and life expectancy is long, then HbA1c of less than 7 milligrams per cent should be aimed for. But if the patient is frail, prone to hypoglycemia, and life expectancy is short, then it will be quite acceptable to relax and accept an HbA1c of 7.5 or 8 milligrams per cent. Most diabetics will need to take medications to help keep their sugar levels under control, and these are just some of the drug classes that are available for use. They range from the oldest metformin, which is still a first-line recommended drug, to the newer SGLT2 inhibitors and DPP4 inhibitors. All of these drugs have their advantages and disadvantages and will very often need to be taken together for maximal benefit. Physicians are also guided in their choice of medication by considering each drug's efficacy and ability to lower HbA1c and blood sugar levels. Then they will need to balance it off with its side effect profile, including its propensity to induce hypoglycemia in the patient. In case you are wondering what HbA1c or glycosylated hemoglobin is, it is a measure of the amount of glucose that coats or attaches itself to the red blood cell. Since red blood cells stay in the circulation for about 120 days, HbA1c reflects the average glucose level over a period of 2 to 3 months, giving us a broader view of glucose control versus the FBS, which is similar to a snapshot of the sugar levels at one point in time. HbA1c has been shown to have a direct relationship with the development of the most common chronic complications of diabetes, namely blindness, kidney failure, neuropathies, heart attacks, strokes, and sudden death. Diabetes is never cured. However, it can be controlled when the patient and the physician work together as a team to achieve best control and maintain good quality of life in the decades to follow. Now, one of the most common complications of diabetes is the development of peripheral neuropathy. The peripheral nervous system includes all the nerves that come out of the brain and spinal cord. There are three main types of nerves: the afferent or sensory nerves, the somatic efferent or motor nerves, and the autonomic efferent nerves, which innervate the viscera. There is a reflex arc between the sensory and motor nerves passing through the spinal cord, and this allows an instantaneous protective response to noxious stimuli. This is what happens when we automatically withdraw our hands from danger or excessive temperatures. In a person with peripheral neuropathy, the sensory and motor nerves become diseased, making them less efficient. So the person with sensory nerve damage may feel numb or be too sensitive to the stimuli, causing the sensation of pain. If the damage is to the motor nerve, then it can mean that the patient cannot move the hands and feet appropriately or will not be able to withdraw from the painful stimulus, resulting in wounds and tissue damage. Nerve damage may be due to multiple causes, such as physical trauma or a laceration which can sever the nerve itself. More commonly, it is a combination of factors that come together to injure the nerve, as you can see from this list. Of course, diabetes is one of the most common causes of neuropathy. There are millions of diabetics worldwide, and in most cases, by the time these millions start to develop symptoms, the nerve damage will already be significant and possibly irreversible. They estimate that 50% of all diabetic patients already have clinical and subclinical neuropathy, making it the most common type of neuropathy in a resource-abundant region. There are 4 patterns of diabetic neuropathy. Most people complain about distal symmetric polyneuropathy, which affects the hands and the legs, but it is also possible to have spotty involvement of the extremities or pure autonomic involvement affecting the intestines, the bladder, and the heart. Interestingly, the peripheral nerves do have the ability to regenerate and reconnect, given an optimal environment. It is the presence of Schwann cells in the nerve sheath, which helps the nerves recover and restore function. On the average, damaged peripheral nerves can grow back at a rate of about 1 inch per month or 1 millimeter per day. With that in mind, there may be hope to reverse the progression of the neuropathy if caught early enough. So, what can be done? It has been suggested over the decades that prevention or slowing down of the progression of neuropathy may be possible with the use of vitamin supplements. What would be the basis for this claim? According to an article from the Harvard T.H. Chan School of Public Health, there are several elements whose deficiency is associated with the development of neuropathies. First, let's look at thiamine or vitamin B1. Thiamine is a water-soluble vitamin which plays a vital role in the growth and function of various cells. Only small amounts, however, are stored in the liver, so daily intake of thiamine-rich foods is needed. People may develop thiamine deficiency due to poor intake, decreased absorption in the gut, or through increased losses in the urine. In such a situation, the patient with thiamine deficiency experiences weight loss, confusion, memory loss, lowered immunity, weakness, and peripheral neuropathy. A severe thiamine deficiency is known as beriberi, which causes severe muscle loss, a flabby heart, and diminished feelings in the hands and feet. Another manifestation of thiamine deficiency is the Wernicke-Korsakoff syndrome, which is associated with alcohol abuse. Patients would usually present with confusion, loss of muscle coordination, and peripheral neuropathy in this sequelae of severe alcohol abuse. So, supplementation with thiamine or vitamin B1 has been done in the hope of avoiding any undue neurologic damage. The recommended dose is only 1.2 milligrams daily for men and 1.1 milligrams daily for women. Apparently, there are no reports of adverse reactions to higher doses of thiamine, emphasizing the safety of the supplementation. Pyridoxine or vitamin B6 is a coenzyme that assists in processes that lead to the breakdown of proteins, carbohydrates, and fats. It is also important in the maintenance of normal levels of homocysteine and supports immune function and brain health. A deficiency of pyridoxine or vitamin B6 may be encountered in conditions which affect absorption of nutrients in the gut. These conditions include kidney disease, autoimmune intestinal disorders such as celiac disease and Crohn's disease. It may also be caused by alcoholism. Since pyridoxine deficiency is usually associated with low levels of vitamin B12 and folic acid, and mild cases usually have no significant manifestations. However, if a severe deficiency occurs, this usually presents as microcytic anemia, depression, confusion, and lowered immunity. A word of caution though, there is toxicity associated with a high intake of pyridoxine or B6, and this may manifest as ataxia or loss of control of body movements, nausea, and neuropathy of hands and feet. Supplementation with pyridoxine is allowed at less than 1.7 milligrams per day, and there is an upper limit of safety. This was a 2022 statement from the Australian Department of Health, which reported that pyridoxine or B6 can cause peripheral neuropathy, and this resulted in a lowering of the allowed daily limit for adults and children from 200 milligrams to 100 milligrams. Interestingly, the Philippine FDA had already implemented that advice to lower the daily pyridoxine dose to only 100 milligrams since 2018. Vitamin B12 or cobalamin is important in the formation of red blood cells and DNA, and also plays a major role in brain and nerve cells. Although it is quite accessible in the food that we eat, cobalamin still needs to be released from food by stomach acids, after which it combines with the intrinsic factor protein to allow greater absorption. Despite its ready availability, it is still possible to develop a deficiency, especially among vegetarians, since B12 is found primarily in animal products. Any situation that affects the level of gastric acid and intrinsic factor in the intestines can decrease B12 absorption, so it is a good idea to be careful with the use of antacids and protein pump inhibitors. Any type of intestinal surgery which results in a shorter intestinal tract may decrease vitamin B12 absorption. Finally, commonly ingested medications such as metformin can block vitamin B12 absorption and may lead to elevated homocysteine levels and increased risk for cardiovascular events. Other signs of B12 deficiency are megaloblastic anemia, where red blood cells are larger in size, fatigue, weakness, and nerve damage and dementia. So supplementation and maintenance of adequate vitamin B12 levels may be beneficial. The recommended daily adult dose is 2.4 micrograms per day with no identified toxicity level. In fact, Oral doses of 2,000 micrograms per day have been suggested to be equivalent or better than intramuscular B12 in the restoration of serum B12 levels and reversal of hematologic abnormalities among patients with documented vitamin B12 deficiency. The last vitamin that is associated with peripheral neuropathy is vitamin E. Most people think of vitamin E as an antioxidant. However, a deficiency in vitamin E levels is also associated with retinopathy, peripheral neuropathy, and ataxia. The recommended daily dose for vitamin E is only 15 milligrams or 22 international units per day, but many supplements actually contain from 400 to 1,000 international units. There have been reports of excess bleeding incidents in people who are taking blood thinners or those who take doses greater than 1,000 milligrams daily. And this is why an upper limit of intake has been set at 1,000 milligrams or 1,465 international units daily. In summary, peripheral neuropathies may occur as a consequence of nerve degeneration or damage from various metabolic conditions, and diabetes is invariably associated with it. It is important to remember that neuropathies may also be produced by certain vitamin deficiencies, and this is the basis for the suggestion for ensuring adequate intake from natural food sources such as vegetable and plant oils. Supplementation may also be done, but the individual and the doctor should be aware of the proper dose and content of each preparation to avoid adverse events or toxicity consequences. That was our brief overview of diabetes mellitus and its common consequence, peripheral neuropathy. It is important to remember that diabetes mellitus can be controlled and its major complications delayed or prevented, but this can only be achieved if the disease is caught early and managed effectively.